In the high-stakes environment of an ICU or CCU, managing acute coronary syndrome, which encompasses unstable angina and STEMI, requires a rapid, rhythmic approach to stabilize the myocardium and prevent further necrosis. Here is the clinical roadmap for managing ACS from arrival to stabilization. Before the labs even come back, the goal is to decrease myocardial oxygen demand and increase supply. Antiplatelet loading, aspirin, to be chewed for faster absorption from the buccal cavity. P2Y12 inhibitor, loading dose of clopidogrel, ticagrelor or prasugrel depending on the planned intervention strategy. Start anticoagulation with either unfractionated heparin drip or enoxaparin. In the ICU, unfractionated heparin is often preferred for its short half-life if the patient is headed to the cath lab. Nitroglycerin sublingual or intravenous to reduce preload and dilate coronaries. Avoid if there is right ventricular myocardial infarction, as it can lead to hypotension, or if there is a recent use of phosphodiesterase 5 inhibitor, that also can be catastrophic. Oxygen to be given only if SpO2 is less than 90%. That is the result which are shown from the AVOID trial. Morphine is reserved for refractory pain. Use cautiously as it may delay absorption of P2Y12 inhibitors. The ICU team must differentiate between a plumbing emergency, that is a case which should go for percutaneous coronary intervention, and a medical management case. The 10-minute ECG, look ST elevation, ST depression or T-wave inversion, that is NSTEMI or unstable angina. 10-minute ECG is not taking ECG for 10 minutes, but when the person arrives in the emergency room, you should get an ECG within 10 minutes. That is a standard. Biomarkers, high sensitivity troponin. A flat high troponin might suggest chronic leak, that is causes other than acute coronary syndrome. But a rising or falling pattern confirms acute injury. And scoring can be done using Grace or TIMI scores to determine if the patient needs the cath lab now, urgently, or within 24 hours. That is early invasive strategy, or can be managed medically. Then comes the revascularization strategy, that is the definitive fix for the plumbing issue, percutaneous coronary intervention. For STEMI, that is ST elevation myocardial infarction, usually due to total occlusion, primary PCI. Goal is door to balloon time less than 90 minutes. And fibrinolytics, if PCI is unavailable within 120 minutes, use alteplase or tenecteplase. In non-ST elevation myocardial infarction or unstable angina indicating partial or intermittent coronary occlusion, invasive strategies, coronary angiography and stenting for high-risk patients, those with hemodynamic instability, refractory chest pain or high Grace score. Second is ischemia-guided strategy, medical management for low-risk patients, moving to the cath lab only if symptoms recur or stress tests are positive. Once the initial stabilization is over, post-event management begins. Dual antiplatelet therapy, aspirin plus P2Y12 inhibitor. Beta blockers start within 24 hours if there is no heart failure or cardiogenic shock to reduce workload. High-intensity statins for plaque stabilization. ACE inhibitors to prevent cardiac remodeling especially if left ventricular ejection fraction is less than 40%. Hemodynamic monitoring. Watch for the CLIP class signs of heart failure. Rhythm watch. Monitor for ventricular tachycardia and ventricular fibrillation, which are common in the first 48 hours, or new onset atrial fibrillation. To summarize between STEMI and NSTEMI, in ECG, STEMI will show ST elevation and STEMI will show ST depression and or T inversion. Troponins are elevated in both cases because it indicates myocardial necrosis. In pure unstable angina, it may not be there. The artery is usually 100% occluded in STEMI, while it is partial or intermittent occlusion in NSTEMI. The urgency is immediate cath lab within minutes for STEMI and urgent to elective hours or days in NSTEMI.